Thank you for the opportunity to present our study on the role of laparoscopy liver resection for the treatment of hepatocellular carcinoma in liver transplant center. I am Duilio Pagano, and I am presenting it on behalf of Professor Salvatore Gutadauria, the primary investigator and the chief of our department. As you know, minimal invasive surgery, and particularly laparoscopy liver resection, is carried out as a valid option to bridge the stay on the waiting list for transplantation of patients with end-stage liver disease complicated by hepatocellular carcinoma. On the other hand, liver transplantation is limited by a chronic and dramatic shortage of donor organs. Therefore, multiple strategies and surgical technical improvements have been implemented over time to reduce the rate and severity of liver transplantation recipient complications and thereby optimize graft and recipient survival. Here, we report our series of liver resection and transplantation for hepatocellular carcinoma in our transplant center from 1999 to 2021. This is our study population, and data were retrospectively gathered by experienced medical personnel using a common electronic database about patients underwent surgical treatment for hepatocellular carcinoma. Category variables were summarized by means of frequencies and percentages, and continuous variables by means of median and interquartile range. An interesting turning point since we started adopting minimal invasive surgery was set in the year 2016, during which we increased our resort to laparoscopy liver resection from an episodic usage ranging from 0 to 70% of all liver resections each year to a standard routine procedure whenever tumor spread and morphology made it possible, thus achieving an annual mean rate of 42.7% of laparoscopy liver surgery, ranging from 37% to 55%. Of the 140 patients successfully treated for hepatocellular carcinoma, 108 was male, median age was 60.5. Most common hepatocellular carcinoma etiology was a HCV infection. HBV infection as secondary in 18 patients. NASH-related disease was increasingly noted during the last years, and at least adult correlated cirrhosis in 6 patients. Anatomical resections were performed in 25 patients, namely 16 single segmentectomies, 7 double segmentectomies, and 2 right hepatectomies. Six patients underwent to transplant after laparoscopy liver resection. Median time from laparoscopy liver resection to liver transplant was 20.1 months. Of note, 1 patient underwent to transplant after open liver resection during the same study period. During the same period, we report here our laparoscopy liver microwave thermal ablation and related intrahepatic location of hepatocellular carcinoma lesions in 61 patients with chronic hepatic disease. In 8 cases, we have performed a liver transplant after laparoscopy microwave thermal ablation. Here, we report a case of a patient undergoing laparoscopy liver resection surgery for hepatocellular carcinoma located in the 7th hepatic segment. As you can see, laparoscopy resection was guided with the indocyanine green fluorescence. The postoperative course was uneventful, and the patient was discharged on the 5th postoperative day. The patient is currently being evaluated for potential inclusion on waiting list for liver transplantation for worsening portal hypertension and moderating ascitic compensation. We can conclude that our series recipients in the liver transplantation list performing surgical procedure to bridge or downstage the hepatocellular carcinoma have a great advantage from the liver invasive approach, mainly due to prevention of the postoperative abdominal lesions in patients with secondary portal hypertension. Thank you.